So when I started at CMS, not that long ago, I was out in the nursing world and concerned about quality and caring and, whatever realm I was working in, whether it was med-surg or the emergency department or the recovery room, whether it was as a staff nurse or as a nurse manager or something in nursing leadership or QI or whatever council committee I was assigned to. I always have had sort of a yearning about doing things that make sense, doing things, promoting things, facilitating things that make sense for the people who can't speak for themselves. Dates way back to when I was a social worker. It goes, only amplified with my training in San Francisco and learning on my feet while working with AIDS patients in the 80s. How do you help somebody who can't help themselves? So I start my job, I'm working for Mary Pratt, who was introduced and spoke to you all yesterday and today. And when I'm thoughtful, I pace. So I'm pacing in her office and I'm walking back and forth and I'm thinking, I really wish at the MDS conference that we could talk about quality and have a discussion about caring. And she said, well, we can. Really? We can? She said, absolutely. This is the right time to do that talk. Like, okay, cool. Wow, that was like freedom, to come up with some zany idea about actually having some kind of a discussion, a forum, an opportunity to have presentations by clinical experts who actually really care about the quality, who have devoted their life's work, their professional life's work, to quality and caring. And to offer that discussion at this conference. And it just happened to be that we doubled the size of the conference. And when I said to the conference event folks here at the hotel, I said, I think we might just need the little room. And she said, oh, no, you want the big room. They'll come. And here we are. So we're going to talk. Like I'm talking. I'm just going to talk to you now. The panel they're going to each introduce themselves. They're going to share with you somewhere in the journey of where we have been, where we have gone, where we're going to, what their passions have been, what caring means to them, how do they measure quality, along those lines. And after they're done presenting that for you, then we're going to have an open discussion, and I'll be the person running up and down with the mic. You don't have to use the corner mics. I'll bring the microphone to you so we can have a discussion about your thoughts, concerns, visions, because that's how change does happen. We sort of have these impromptu think tank opportunities, and then we sort of take it from there, and then it grows into something. Just ask this panel how that works. So the folks that we have is Dr. Levenson, Rosemary Dunn, Karen Schoeneman, Dr. Christa Hijlo, Dr. Shari Ling, and Dr. Debra Saliba. It's an amazing panel, and they truly have devoted their professional lives to quality. So we will start. Dr. Levenson.
Thanks. It's a real privilege and pleasure for me to be here. We each have 10 minutes, by the way. I'm a long-term care medical director. I'm medical director of 6 facilities here in the Baltimore area, and I've been actually working in nursing homes since August of 1978. So I was cleaning out some files in my house just a couple of weeks ago, and I happened to come upon this. This bright orange folder that says HICFA. And I opened it up, and in there were several letters from early 1989 from a guy named Wayne Smith. And it was an invitation to our professional association, the American Medical Directors Association, to review the original interpretive guidelines, or the first of many iterations thereof. So that just reminded me of how long all of this has been going on, and that I've had the opportunity and the privilege to be part of a lot of it. As among other things, besides working in the field, I've also, since the late 80s, had the opportunity to work in various capacities with a number of people at CMS or its predecessor, HICFA, particularly the nursing home division, and to give a lot of input to try to improve the clinical pertinence and the applicability and implementation of a lot of these guidelines and regulations. So it reminds me how much work and effort on the part of so many people have gone into developing and implementing tools to try to improve long-term care. And also that a lot of this has been successful. So it's appropriate to pay tribute to all the fine people such as yourselves who have worked in the field and tried hard to do the right thing and tried to advance the field and advance the care in those settings. However, despite this progress, there's still this unrelenting theme among the public and many others, the mass media, for example, that the care still needs a lot of improving and that there's still something not quite right about it. They can't always pinpoint it, but it's just not quite right, or it's not good enough, or somehow it's highly problematic. So, of course, one possibility is that what we might call the conventional wisdom is that the care is not as good as it could be because people haven't done enough of what they've been told to do. But there's also other possibilities. One is that they have been doing what they've been told to do, and maybe they haven't always been told the right thing. Or that they have been told the right thing, and maybe they've misunderstood or misinterpreted what they've been told, or not understood how to apply it. So what is this quality care that we've been trying to achieve for more than the past quarter century? Well, in 2001, the Institute of Medicine published a report entitled Crossing the Quality Chasm, and that's as good a place as any, just as a foundation. They said that we should aim nationally for care that's effective, efficient, patient-centered, safe, timely, and equitable. That seems fairly reasonable and pertinent to what we're trying to get at. So when done properly, geriatrics is among the most holistic and person-centered of all disciplines, and it's been around for about 60 years. It incorporates, that is in a formal fashion, it's been around longer than that informally, incorporates a balanced approach to the physical, functional, and psychosocial dimensions and aspects of existence, and it promotes key principles such as all symptoms have causes. Multiple problems or symptoms can have common causes, and a single cause can result in multiple symptoms or problems. And symptoms often occur in remote parts of the body. For example, changes in brain function can be the result of pneumonia, or changes in appetite and weight may be due to a medication given for a urinary or behavioral problem. So a lot of the efforts to try to improve long-term care have been based on developing tools and so-called best practices. Many of these tools, such as the MDS and the RAI, have had the input of individuals from diverse disciplines, including geriatricians. So you may recognize the name Norm Abrams, who's not a geriatrician, but he is on PBS and has been for many years, This Old House. He's a master carpenter and not a geriatrician. He may have built a lot of furniture for nursing homes, but he probably has not really worked very much in them. And yet, no pun intended, he hit the nail right on the head when he was quoted as saying, "The tools do not do the job. Instead, they facilitate the performance of those who already know how to use them." In other words, tools are a means to an end, and they have to be used properly and in the right context in order to produce desired results. So imagine that I or any of you are taken to Home Depot and told, we can have access to any tools we hear we want. Or even better, we can have access to all the tools that we want. So does that now make us a master carpenter? Or if we get all these tools and they're given to us and we can use anything we want, does that mean we now know how to build a house? So after all, even master carpenters who could build houses don't necessarily know how to design them. Otherwise, we wouldn't need architects. They don't necessarily know what the best kind of house or the right kind of house to build for various conditions or geographic locations, or how to identify the causes of problems with the house, or how to prevent or repair such problems. So I think we can apply those lessons to all of these efforts to improve quality in long-term care, especially those to create and refine tools. The RAI, including the MDS, are tools, and as with many tools, they serve a specific and very useful purpose. They have their virtues and their limitations, but they have to be used properly in order to attain the desired result, and their misuse carries potentially harmful consequences. So what does this mean, and what can each of us do to try to ensure that these tools are used properly as a key driving force for quality? Well, as was stated yesterday, the MDS 3 doesn't really break any new ground, but it does improve in some ways on previous versions. It doesn't change the biological reality of how individuals act or react when they're old, frail, or young and chronically ill. And it doesn't change the principles of how we have to look at causes and consequences and figure out what relates to what. So, for example, despite the best of intentions, there have been some issues in the MDS-2 related to the approach to depression. The MDS-2 provides a laundry list of symptoms that could represent depression, and then it's linked to a quality measure about having depression, signs and symptoms, without necessarily having a treatment. The trouble is, this isn't really a way to diagnose a mood disorder or decide when a certain mood constitutes a problem or whether it needs a medical treatment. So, despite good intentions to try to identify and treat more cases of depression, there are adverse consequences potentially of misdiagnosis or excessive diagnosis or premature conclusion drawing or failure to look at evidence that may not be consistent with our preliminary conclusion. For example, antidepressants can cause falling or change in mental status or even serious complications such as serotonin syndrome, which can be actually related to behavioral disturbances and death. So someone asked yesterday, is it okay to only use the information provided with the RAI as the basis for care planning? I thought that was an interesting question. And I'd say, well, it depends. Suppose your next flight, maybe the flight back home, you get on and the crew makes the following announcement. Welcome aboard, ladies and gentlemen. We're flying today to Texas. And we want you to know we're all familiar with the rules in the FAA manual, but we can't guarantee that we use anything else to help us fly this plane. However, we just wanted to reassure you. So everyone has an obligation to give what I call biologically sound care and biologically sound advice. We not only need to talk about how to use these tools correctly, but also much more about their limitations and risks. That is, how and when not to use them, or when we can't really rely on them or rely on them fully. Any data set, whether the MDS or anything else, necessarily lacks context. That is, how do all these pieces of information fit together? A good example that I like to point out is that there's a big difference in causation and approach if delirium precedes anorexia and weight loss, or anorexia precedes delirium. Because in the first case, the delirium may be the cause of anorexia, and in the second case, the anorexia may have caused fluid and electrolyte imbalance that's the cause of delirium. So the MDS is not really a contextual instrument, it's not a historical instrument, it doesn't give the details of what led to what or what caused what or what related to what. It just gives you data, and so we really have to go beyond it. And there's lots of evidence that the history is really the most important thing to practitioners. It's like 8 times more important than either the examination or the laboratory tests in making a diagnosis and identifying causes. So the RAI, the RAPS, the CATs, and all these resources are useful, but they only provide laundry lists of possibilities, and it's really up to us to go further and recognize how to take them further, to find the causes and identify cause-specific interventions where they're possible. Another favorite example of mine is that about what to do when there's behavioral changes. So somebody asked yesterday, well, what's the first thing everybody does when there's a behavioral change? And of course, as I've heard so many times, get a urine. So one time I heard that in a meeting, I said, no, don't get a urine, get a history. Get the details. because often just jumping to a conclusion misses the boat. And it's terribly important to get the details, because we could say, well, so what if we treat this alleged UTI with antibiotics? So what? And the answer is, well, there's a lot of so whats, ranging from because all antibiotics interact with coumadin and can make people bleed, all the way up to we can get antibiotic resistance, anorexia, and complications such as allergies and rashes. So now, in winding up here, let me tell you a word that's often been overlooked in the unbalanced, sometimes unbalanced push to find and treat certain common problems based on either conventional wisdom or the MDS. The word is hypothyroidism. Why is hypothyroidism so important? Well, it's on the care area triggers, but it's just one of many. However, hypothyroidism can actually trigger 12 or more of the CATs: delirium, cognitive loss, visual function, ADLs, urinary continence, etc. So 12 of the 20 can be triggered by delirium alone, by hypothyroidism. It's common. It's fairly readily identifiable. There's a simple screening test, a TSH and a free T4. And when treated adequately and appropriately, it can change a person's life. In my 6 buildings in Baltimore, I'd say between the 6 of them, we find about 1 case a month. So if that's 1 case a month, and that's 1/3,000th of the nursing homes in the United States, then maybe there's as many as 20 or 30,000 people a year who could be helped to a better life and much more person-centered care if somebody just did a thyroid screening test instead of a urine or a psych consult. So long-term care, guessing is often necessary, but wild guessing can be problematic. There's not necessarily a one-to-one link between symptoms and causes, and it's our job to go further and to think about how do the causes and consequences interact. We all have a special obligation, including those who work in nursing homes and those who consult in the field, those who advise the facilities, those who regulate and oversee, to rethink, to use the opportunity of the MDS 3 to rethink some of what we've been telling people and to make sure that the tools that they're given have the best possible advice. Of course, we can't stop people from buying a circular saw and doing great damage to themselves or others, any more than we can stop everyone from misusing the MDS. But it's our job to rethink the conventional wisdom and common practice and consider how we might rebalance and do a better job of using the tools that we have and are giving people. So to me, that's the lesson that we can get out of all this, that the best quality care comes from understanding what we're doing, consistently doing it well, and providing pertinent advice to others that helps enable safe, effective, efficient, timely, equitable, and person-centered care.
Well, thank you. It's hard to follow. My background is as a nurse. I started working long-term care back in February of 1972. Prior to that, I'd worked in a hospital. I had a baby who had born with a cleft lip and palate and had needed a lot of care, feeding with a dropper and whatever. And so when he was 5 months, went to work. When I did, he was ill many times, but I thought the nursing home work would be much less difficult than working in a hospital. What a surprise. I lasted only 7 months in the nursing home. I decided it was not something I wanted to continue to do. And particularly when the time came, this is when I was asked to work on the evening shift to care for give medications directly for 90 patients and do treatments and other things. So we've come a long way since then. But I tell you, it's been not without struggles. And those are the times that I've actually thought, well, there must be ways we can change this. This is not right. And also, I remember also doing treatments and having to, for every little square of gauze I used, I had to kind of check off how many I used and whatever, and it just was so much a waste of my time. You know, why not prevent these decubitus ulcers or whatever I was being treating, and instead of paying for gauze or other time and effort spent to care for someone with bed sores, or they called them back then, or pressure ulcers as we say them today. So those are some of the things that kind of motivated me to kind of go forward with my career in nursing, and which I've done for many years, more years than I'd like to think about, and since then have actually continued to work in long-term care as a staff development in a nursing home, and also as a nurse surveyor. I've also done psychiatric nursing for several years, and have also worked as at CMS most recently before retiring, and now working as a nurse consultant for CMS. So it's been a long progression in time and effort to really hang in there, kind of work with what needs to be done to make some changes. And having worked in all those areas, have been involved with the evolution of a lot of changes. Just thinking today, actually, I've started nursing. I hate to say this, but I will date myself, but we can probably edit this, hopefully. 1959, I went into nursing, and so I've worked all those years in addition to having a family. So it's been really a very rewarding career, and continue to do so. So I would like to share with you a little mnemonic that I've developed relating to quality, and it also relates to what we're doing with the MDS 3.0, hopefully. One of the things, so the Q I'd like to say stands for ask questions, and as the 3.0 also we're now asking a lot of questions. We're asking questions of the resident, we're asking questions of the family or the staff, whoever is close to the resident. That's who we ask questions of. Also, one of the other things, hopefully everybody is qualified to provide the care and services. We also have long-term care. Now you have nurse aides who are required to pass certain criteria. We also need to be sure that they're receive the proper training, and it should be ongoing. It's not just that one time that they go through training. It's ongoing. Whenever you have a new resident that comes in with a particular disease or entity that needs, say, trachea care or whatever, you need to be sure that they're trained to care for them. Also, for the U, I thought perhaps there are several things I thought of, and one of the things is to be understanding of others. So you really need to understand where they're coming from. It's not just what you think that's important for them. It's also to listen to what they want, and to understand that, and maybe come to some understanding they should be informed of the risks and consequences of any decision making. So therefore, try to help them understand all of those things. And also for the A, for quality, I thought all the times, all shifts, as appropriate, obviously, but at all times, be consistent with what you're doing, and be sure that everyone else is consistent as well. And having been a director of nurses in a facility, I found that very difficult. Unless you're there 24/7, it's very difficult. One particular place I was director of nurses was the transitional care unit, and as the post-operative residents, patients at that time needed a particular equipment for continuous circulation, and the operation of that equipment was not working. I went in on a Saturday evening and found out that there were 3 pieces of equipment that were not being operational. So therefore called the administrator, got the physical therapist there to repair their equipment, get it, and these 3 patients would not have received their treatment. Now, I don't know what made me go in that Saturday night to find out what was going on, but I did. And I was late at night to about 11 o'clock to make sure everybody got the care and services they needed, and the doctor had ordered. So it's just a matter of, constantly being aware of what their needs are and going and being there to provide them. Also, you need to love what you do. I think for Al, this is, you got to really love what you do, and it shows. It really does, and the residents perceive, they know when you're showing kindness, consideration, compassion. They're very receptive to that, and so I think it's we have a lot of technology today, but it doesn't really take the place of all that care and that they should be receiving and the touch. I don't think we do as much as we should in that respect. And for the I would say for the interdisciplinary, all professions working together. I attended a conference one time, and the speaker mentioned it was providing care to a resident was like the resident was the center of a wheel, the hub of the wheel, and all the other disciplines were sort of like spokes that would go out. But in order for that wheel to turn, you really need to have everybody working together to achieve the common goal for the resident. So it's something, it's a concept that I never forgot, that everybody should be working toward the same goal. You have lots of disciplines, but it's multidisciplinary versus interdisciplinary. Interdisciplinary is when everybody's working together to achieve the common goal for that resident. So I think you'd want to keep that in mind as well. And therefore, it leads to teamwork, everybody on the team actually working together to achieve that goal as well. And that includes the nurse aides. It's not just all the other professionals. The nurse aides are a very important part of this team. And the why, well, I've kind of thought of a couple of things, but one of the things I thought initially was you make the difference. You can make the difference, or at least make an effort to make a difference. I've always set my standards rather high, but actually found that I didn't always achieve them, and it was really frustrating. But I didn't ever stop trying to aim for them. So, and also the staff and people around you, help them, encourage them to achieve their goals and their career. Also just accept where they're at and just help them aim higher to provide that quality of care that you need. And therefore, it would yield all the benefits of quality at that point. So that's what I was thinking of at this, regarding this session. I also thought that, as I mentioned before, the technology has changed. I've seen lots of things. I was just reminiscing from having to sharpen needles to the back in 1959 or whatever, to the advent of plastics and disposable equipment and all those kinds of the technology. Once worked in a hospital, was a research hospital, and I felt like Alice in Wonderland. We had all this new equipment, the hypothermia blankets to bring down the temperature. There's a whole lot of stuff out there that I was not familiar with, having worked in a very small hospital in Vermont and then moving to a city where they had all this equipment. It was just, so throughout the country it changes, not everybody's on the same page at the same time with technology and services. In the rural areas it's very difficult. I remember once in a nursing home when I was a surveyor, they had a need for an occupational therapist for a resident. The facility admitted the resident, but then when we surveyed, found that they were not providing occupational services as ordered. So they got, obviously they were cited for not complying with offering the services. So they're very rural areas. They don't have all the professionals that you would have in the city, available in the city, so in metropolitan areas. So it's a little bit of a challenge in some places as well. So over the years, hopefully, I've been able to help others implement some changes. And always, I remember working in a psychiatric hospital, having worked previously in a nursing home, and I said, this is back in 1978, and I said, where's that book, that blue book, the one that has all the regulations? And they said, what do you mean? I said, there's a book that, that you can get all the regulations and guidelines as to how to provide care. Where's the privacy? I was asking all these questions. What is infection control? I just didn't understand that psychiatric hospitals had different regulations at that time. So I didn't So I was asking them. So finally they had the state health department come and do a review. So I was always questioning, and I was always asking, why aren't you doing the things that this other facility is setting? So eventually they did make some changes. They did put in some privacy curtains. They did affect some changes that I had requested. Hopefully, you too, as you are in your profession, you do not lose faith and just continue to aim for quality, and although some challenges along the way.
Hi, folks. I'm Karen Schoeneman. I am the Deputy Director of the Division of Nursing Homes, and we are part of the 3 divisions that have sort of jointly agreed upon the implementation of the MDS. But I'm also an old social worker, so that I find it actually funny. They've parked a social worker right in the middle of the clinicians here. But I am not afraid. I'm not afraid. No. Because I've worked with nurses all my life, and certainly doctors too, but mostly nurses, because I worked long-term care for 17 years before I got to be a Fed. And I always thought it was such a wonderful privilege to help my nurse, help the residents, and work on the care planning. I am one of the founders of the Culture Change Movement and its lead at CMS. I've also been the lead of Quality of Life. Thank you. And because I get into meetings with the pioneers and eat-in people and the deep thinkers of the movement, and I just came back from one this weekend, a little gathering of 18 of the pioneer founders at a lovely little retreat. And we talked about what good is a good care practice to the person who doesn't want it, who doesn't want the diabetic diet, who doesn't want to stop drinking or smoking, who doesn't want to be safe in their wheelchair but wants to get up and go, even when they're weak and wobbly. What good is confidently delivered care by a person who is cold, militaristic, and really rotten in social skills, who makes you feel dependent, lesser than everybody, old, unwanted, but competently changing a dressing? What good is that? It's good enough to make people depressed enough to want to die. It's not good enough to have competent care. And it's not good enough to have a clinician solely decide what you should get in your care plan based on that assessment. For we all know, if you have 10 people with diabetes, they want different things with their care, and they have different levels of it, and different decisions and different capacities, and different families who are lobbying you one way or the other. Remember, in social service, we're the complaint department. And the nurse would say, the Jones family is in, talk to them. Or Herman and Peter are fighting again, talk to them. 2 residents, one wanted to put magazines on the chair, the other one wanted to sit in the chair. Millie, Hermione, they both want to sit in the same seat in the lobby, talk to them. And so I got used to conflict and bringing everyone together to talk. And I find that that works. When you actually can get face-to-face and calmly and creatively together, say, let's set a boundary here. And the boundary is safety, rights. Those are the 2 ends of almost a yardstick. But they're not a light switch. They're not like on and off. One's on, one's off. There's a meeting in the middle for every person, every day, for every issue. How much safety? Because this one moves, the other one moves. More safety, less rights. More rights, less safety. This national discussion has yet to be held on a really high national level where all the organizations are held clinically. And it's going to be next month as we, the pioneers in CMS, have co-sponsored a dining symposium that was supposed to have been held in February here. What was happening that day here? About 50 inches of snow. The government was closed for an entire week, and 1,150 people couldn't come. And some of them were already there, and they couldn't leave. But did we let us be defeated? No. I want you to know that although the symposium isn't being held, the speakers who were going to speak, the pioneers have decided to take our CMS contractor and have her do a webinar with each one of them to hear what they have to say. Doctors, nurses, speech therapists, clinicians, former surveyors, putting the cards on the table about the ethos of clinical care. And it's going to be in the topic of dining, but as a bellwether to all clinical topics, putting that tug, the fear of the surveyors, the fear of the family, the fear of the litigators, I need to do this in my profession, I'm afraid of the doctor, I'm a nurse. The doctor, I'm called in the middle of the night, I have to make a decision. Put it all together on the table. We're calling them all together. And so that second part, which was going to be the talking, the face-to-face, eyeball to eyeball, is going to happen on May 14th. Steve is coming. Christa on my left here is coming. She's from the VA. And we are going to have all the national groups, advocate, clinician, industry, all the clinical types, the pioneer types, the innovators, say, let's have a new dialogue. Let's start a new day, a new way to say, what is the good thing to do? I think it's to know the resident. And I think it's to love the resident. And I think it's to approach the resident as a treasure. Here is the history of our nation, sitting in front of you, a 99-year-old woman who's been through World War II and horse and buggy days and the Depression and the stock market crash and, whoa, what you can learn. Maybe she can still talk to you. Maybe she can't. But she's to be revered. And I think as I treated my own mother when she became a little more dependent due to arthritis, when I had to help her a little in the toilet, I would be aware, here I am a daughter. I'm coming into a situation of almost a dignity violation unless it's done with great, great care and respect. And I would do that to a stranger, as with my mother. And so what I would do with my mother when I had to help her a little in that way, I knew she would be embarrassed, is I would ask her a question that put her back in her proper place. I would say, my tomatoes are getting white spots on them. I don't understand why they're dying. And let her tell me the thing that she was truly expert at. I don't understand why my vegetable soup doesn't taste like yours. What can I do to make it better? And so to bring her personhood back, to let her be my mother. I think any elder in society needs to be treated like that by all the staff. How can we, day by day, remember to treasure the treasure that's soon to leave us behind? Our history will just go into books if we leave it behind. When we get to the care planning meeting that comes after this assessment, it's fine if we agree, the staff and the residents. But when we don't, when the staff say, let's give you a shower twice a week, take these pills, go do this, go do that, and the resident said, I don't want that. I would like to have about a half a cup of Four Roses liquor, 10, 15 cigarettes. I'm looking for a woman. I want a little poker. I like to sit naked in my chair. Then the answer is, who wins the care plan? Is it a battle? Should it be a battle? Where can we go? We can't go all the way to total abandonment of all ethos, so we do have to find a place in that middle. And we've got to only do it by continually talking to each other, I think, because quality of life and quality of care are one thing in the eyes of the elder, of the disabled person. And I think it's only separate to people like the feds who put them in different chapters in a book. Thank you.
Thank you, Karen. It's always a pleasure to be in your company. I'm Christa Hijlo. I am the director of the VA Community Living Centers, formerly known as VA nursing homes. We changed the name to begin to dispel the negative image of nursing homes, and we believe that language how we refer to them is significant. And I'm also the director of the State Veterans Home Clinical and Survey Oversight. So in a way, I'm Karen's counterpart in assuring that our state veterans homes are in compliance with VA standards through a survey process. I have a long and interesting history in nursing. I will just tell you little glimpses of it because I could take up the whole time just talking about the interesting experiences I've had, but I started out as a critical care nurse. I thought I was a hotshot nurse at that time. How many of you were critical care nurses? I'm sure a lot of you. So you'll know from whence I come. And, you know, you think in being a hotshot, you can do all these wonderful things, and you think you've learned a lot, but in reflecting back on the most significant lesson that I learned as a critical care nurse, that lesson was to actually look at other people. Look into the eyes of the person with whom I'm interacting, particularly if it's someone that I'm caring for, to whom I'm assigned to be their nurse or their care provider in some way. Look into their eyes to read their spirit, because their spirit is somehow a reflection, tells me something about them, and it gives me messages of how I might improve my communication with them. I learned to look at facial expressions because in the intensive care environment, very often people are comatose or semi-comatose or can't talk because they have tubes in just about every orifice, especially the one that's most significant for communication, and that's their mouth. So I didn't realize I was learning those things, but I was, in fact, learning how to communicate by looking at people. Over the years following that, I had some other experiences, growthful experiences, and at one time I woke up and I was a nursing home administrator. And as a newly minted nursing home administrator in 1989-90, after I finished doctoral work at the Catholic University of America, I was tasked with implementing the MDS. And I thought, again, as a hotshot critical care nurse, I could do this. It was very difficult because it was in a very large facility in Maryland that was in survey trouble. They were on a fast track, and we not only had to implement MDS, the beginnings of MDS, meaning we had to teach staff and everybody how to use it, but we were also trying to survive. So that was trial by fire. And following that, we did turn the facility around. I was hired by VA to manage a program, and again, had some promotional opportunities, became what we call associate chief nurse in one of our largest facilities. And then I was invited to come to our VA central office, where I was asked then to implement MDS for the first time in VA. This was in 2000. So VA actually did not implement MDS when everybody else in the world did. And frankly, when I came to VA, I was shocked that VA was not using MDS. Because the dirty little secret that I had was that I really believed that MDS was a good instrument from the very beginning. I thought it was, maybe it wasn't a perfect instrument, but I really believed in a standardized form of assessing and treatment planning. And so when I had the opportunity to implement MDS in VA, you can imagine the resistance. And the resistance came from all kinds of places. Internal to VA, staff were, some of my colleagues and my staff are here. You know, we're just not going to do this. And the Joint Commission doesn't require it because we were Joint Commission and still are Joint Commission accredited. So Joint Commission doesn't say you have to use MDS, and VA is not under Medicare, so we don't have to do MDS. But I firmly believe that we should, and we did. And as I was beginning the implementation process, I was very frustrated, and I was frustrated not just with the MDS implementation, but I was frustrated with nursing homes in general. And here I was becoming a nursing home guru, and I looked around and I thought, I don't like what we're doing in VA, and I certainly didn't like what we were doing in the private sector. So what are we going to do here, Christa? So I pick up the phone. I didn't know Karen at the time, but I thought, I'm going to get an MDS expert to help us with this MDS implementation process and see if maybe she can offer some insight into how we might proceed. So I called Karen. I didn't know her. I said, Karen, would you come over and be a speaker for us? And she said, oh, sure. We talked about that. And then I said to her, and by the way, Karen, I don't like nursing homes. I hate the way we do it in VA, and I don't like the way private sector does it either. So I just don't know how I'm going to do this. And Karen introduced me to the Pioneer Network, which at that time was newly formed. And I recall going to my first meeting and was very impressed with where Pioneer Network was going, and I thought, aha, that was my aha moment. I will use MDS as a venue for culture transformation in VA, nursing homes. At that time, we called them nursing homes. So that really was the beginning of the culture transformation. In VA, I formed a small group, and actually I had two wonderful groups. I had a group of points of contact, we call them, from our, we have this system called Veterans Integrated Service Network, where we are divided into regions, 21 regions around the country. We have about 153 medical centers, pretty large medical centers. And so I had a point of contact, some of them are here, for RAI MDS, and then we also formed a small steering group for culture transformation. And we integrated the two. In essence, what we did was, I frankly find the MDS as a wonderful opportunity for the essence of nursing and professional practice to shine through. And how do I see that? Well, at one point I was teaching at the Catholic University of America. I was teaching graduate students and baccalaureate nursing students, and so in my teaching I thought I better look up and find out, what does the ANA, American Nurses Association, how do they define nursing? Interesting definition. And I've held that close to my heart and applied in the MDS process. Nursing is defined in the Nursing Social Policy Statement as the diagnosis and treatment of human responses to health and illness. It's a diagnosis and treatment of human responses to health and illness. That puts a whole new light on our role. And actually, as we continue to implement culture transformation and become better and more skillful at using the MDS process, I'm finding that that definition is applicable to anybody who works in a nursing home. Now, you can say, you know, the practice of medicine, and Steve, you articulated it very nicely. You know, the practice of medicine is very significant in diagnosing and treating illness and chronic disease and helping people through that. And in partnership with medicine, we don't diagnose disease, we don't prescribe medications, we don't prescribe treatments. But in collaboration with our physician colleagues as an interdisciplinary team, as we diagnose and treat how this human being that we look at is responding to this terrible thing that happens to them, whether they have a sudden acute illness, like a stroke, that actually causes all kinds of internal changes, body image changes, inability to do certain things that you were able to do before. What's that like for this person? One person can manage it fairly well. Another person is terribly devastated by something very slight. So what is it like for this person? I'm finding that the MDS 3.0, what's impressive to me about the MDS 3.0 and its evolution is that the MDS 3.0 is going to cause professionals, nurses in particular, to look at the person, to look at them and speak with them and elicit their voice. What a gift that voice is. And you know, sometimes that voice is real strong and clear. Sometimes that voice is garbled. And sometimes that voice is confused. And sometimes that voice can't come out audibly. It comes out in other ways, in expressions. It comes out through the eyes. It comes out through body language. That's what this new instrument is calling us to do. It's just an instrument. It's nothing more than an instrument, but it is an instrument of standardized information gathering about a human person, about the human side of the person that sits before us. It causes and calls us to look at them and ask them questions. So I think that the designing of the MDS 3.0 is really quite marvelous. We have to use it. We don't have a choice. We don't have an option. But you know, there are many things in life that aren't pleasant, but if you choose to use them in a manner that moves you to a new place and helps you to serve your residents better, then let's use it that way. I think my final comments to you, I'd like to share what I call the 4 C's. One is that in transforming the culture of care, including what it is that we're doing with how we're going to be using the 3.0, the first thing that calls forth in each of us is a notion of commitment. And we heard today how important the attitude of how we present this instrument and how we present this process is. So the commitment to improved care, the commitment to transform the way we think about the way we deliver care, that's first and foremost. Second, I like the notion of a little controversy and a little conflict. That's the second C, because it's through conflict and controversy that we engage in what I call dialogue. And dialogue means that you share with me what you think, I share with you, and I may disagree with you, but hopefully in that disagreement, we can get new insight. So conflict and controversy is very important. Competence. It's wonderful to have pretty buildings, nice homes for our residents, you know, fancy surroundings, nice gardens, good food, but if you can't provide tube feedings competently, if you can't provide IV therapy competently, if you don't use evidence-based practice standards for the care that we deliver, and we know that the care we're delivering in homes today is at a much higher level of intensity of services than it once was. There must be competence. So commitment, controversy, competence, and finally the last C in my mind is this notion of a community of committed persons, that to the extent that each of us is committed to making a difference, and we find each other out there and help each other move to the next step, we then have an opportunity to make a much better nursing home world, a much more inviting place for our residents, a much safer place for our residents. And goodness knows, hopefully we can find measures for all of this someday. So thank you for this opportunity to be here.
Okay. Good evening, everyone. I am in humble awe of my colleagues here. My name is Shari, Ling. I'm a relatively new medical officer with CMS in the Division of Chronic and Post-Acute Care in the Quality Measures and Health Assessment Group. I am also in awe of all of you. I'm so honestly and earnestly impressed by your commitment and willingness and to voluntarily be here to take part in this discussion. I have a bit of a convoluted path that has brought me here. I'm a gerontologist first and foremost. That means that I am a student of aging. I appreciate and have embraced the aging process, even as it has taking place as we speak. We can't fight it, so we might as well go with it and make the most of it. My first job was with the Veterans Administration, my two colleagues here, in the Depression Research Unit as an undergraduate, as I was obtaining my concentration in gerontology. And it was there and then that I realized how much work was ahead of us as a field, as professionals, and I went on to obtain my master's in gerontology at the University of Southern California. And even as I learned how to do direct service, because that was the track that I was in, direct service in gerontology, I learned how to provide counsel to older adults, to their families who are struggling with the issues of caregiver burden. And the more I worked with the families and older adults with depression, suicidal ideation, the more I realized how much I had still to learn from the patients or clients or families, to learn about the processes that led them into my office, and about the medical aspects of what plagued them. So after finishing my master's, I decided to give it a shot and apply to medical school, and by golly, by the grace of God, I got in. So I've always been a bit of a strange bird in a land of traditional medicine. But nonetheless, I completed medical school at Georgetown and trained in internal medicine, and still fascinated by the complexity of the human body, by the human spirit. I trained in medicine, chief resident at Georgetown, and because it was difficult for me to synthesize how these unrelated parts were coming together to develop a disease process, a unifying diagnosis, I decided to go into rheumatology. So I trained in rheumatology at Georgetown, aches and pains, psychiatric, social, musculoskeletal, mobility, frailty. I embraced that too. But still not feeling completed, I then did my training at Hopkins in geriatric medicine. And there I found my home. So I am I forgot to mention that I'm also my undergraduate degree was in general humanities, but I was a dance major, of all things. So, what did I do with all of this? So I practiced medicine in geriatric medicine at Hopkins, learned about how to deliver care, aspirating joints, taking care of patients in their homes, on the bedside commode, sitting on the bedside commode with my fishing tackle box in hand, seeing patients in the nursing home, learning how to deal with these incredibly sick, complicated patients who were people with a voice. I was the one who caused the facility to get a black mark because I was writing orders for ice cream for my diabetic nursing home patients who wanted it. Thank you. Thank you. I was the one who was wheeling poor Edna down to the lobby out the back door so that she could grab a smoke. Thank you. But I learned so much from these patients. And it irked me to no end that we would lose touch with our residents when they became patients in the hospital. And that's one thing that I would like to speak about, is about connectivity. And one of our greatest challenges is how to reconnect as a system. The nursing home, hospital, we've become these isolated islands, these cities that have no connection, and that our residents, our families, our parents have to somehow survive as we shuttle them, or they're shuttled from setting to setting to setting to setting. And each time, same story. You know, history is a double-edged sword when it comes to the patient or the resident. We need enough information that we understand who they are. And yet we need to remain humble enough to know that we don't know it all, to be curious, to take a fresh look at each patient as they're wheeled in, at each resident, and we need to go the extra mile to understand them. We are all connected. Why are we all here? We're all here in this room at this moment, sharing this moment, because of the MDS 3.0. It goes much further than that. We're all connected. We're connected in this universe. We're connected. There are biological systems that are in play that go beyond us as human beings, involving living creatures of all kinds. We are connected, and we've lost that connectivity. So it's Christa had mentioned looking at a patient, looking into their eyes, understanding who they are. I, as a rheumatologist, I love to watch people move. And as a retired dancer, I find it fascinating. I studied at NIH, well, part of my history I forgot to mention. I worked at NIH for 8 years in clinical research in the Aging Institute. And I studied arthritis, I studied the development of arthritis, and I studied biomechanics. It's about how people move through time and space that matters. And it's about being curious enough to figure out what the causes are, not to assume that the joint is the problem, that the cell is the problem, but how these factors all interact and play off of each other. So I think we need to reestablish connectivity. Now, there's enthusiasm for electronic health records. I use them. I volunteer on as many Monday afternoons as I can steal away at the Veterans Hospital in the clinic. I spent my birthday in the Veterans Hospital in the clinic so that I could actually see patients, talk with them, spend time, remind myself of why I'm here. And although the tools are impressive, they are flashy, they are amazing. It's amazing what we can see with our own eyes through technology, but they are still tools. This is a common theme that I've heard. We need to embrace it, but use it wisely. Apply thought to the processes. And the other factor that brings us all here is our choice. We heard about how some of our residents challenge us in exerting their choice and their decision-making. And we are connected by choice and our choice to be here. One other little story that I will leave you with that reminds me of how connected we are. About 3 years back, my mother was flying in from Honolulu, so, just please get me my special water. She will only drink water that is bottled in Honolulu. So, okay, I'm gonna be the good daughter, so I go out to find this special bottled water, Safeway, Giant, you name it. I'm going through like a madwoman looking for this bottled water because I had decided to, because this is something that my mom had asked for. So in doing so, I finally find the water. I'm desperate to go to my aerobics class at night. I walk in, it is 45 minutes, I'm late. Just at that moment, I walk in, they say, does anyone here know how to do CPR? And I said, oh my goodness, yeah, I do. I had just completed my BLS recertification. I know how to use the machine. So I arrived there, and this poor man had fallen over, hit his head, and was in full cardiac arrest. But if I hadn't gone out to purchase that bottled water, connecting my mother with my decision to go out and actually obtain this special water of hers, I would not have been there in the right time, at the right place to lend assistance. Now, you would think, I would walk away from it thinking, oh my gosh, how lucky he was to have me there. I arrived on time. I was the one who's lucky. I'm very fortunate to be in the company of my colleagues here, in the company of you, and that now that we've established this connection, it is not hard to find us at CMS. There's no mystery as to what our emails are, so please consider it a invitation. If you have thoughts of how to make our processes better, how we can better care for our residents, please. Shari.Ling@cms.hhs.gov, or pick up the phone and call. Thank you for your attention.
Hi, I'm Deb Saliba. I'm a geriatrician. And Karen, I don't know, you said that the anything goes is off the table. I'm from California, so I don't know. We can see here. I think one of the things that's coming out tonight in everyone's comments is that you can't be a clinician if you don't love stories. Because basically, every person is a story being told. And I think that's what we're hearing from Christa, we're hearing from Karen, we're hearing across the table, is that every person is a story that's being told to us as we walk in. When they asked me to be on this panel, I said, well, goodness, what can I add to this group of people who all sort of embody quality and really have been working to approach it? And one of the things that they said to me is, okay, well, you talk about research and what research has to do with quality. So I'll sort of go at it from that perspective just to bring in a little bit different angle here, because otherwise I think I'm in pretty much agreement that, we don't have a dichotomy between quality of life and quality of care, that has to come together. Someone who's short of breath is not going to have a good quality of life. Someone who is in pain is not going to have a good quality of life, and we can't disaggregate those things. But looking at it from a research perspective, there are really sort of two research models that are out there. And there's one research model that's sort of a single condition, syndrome-driven kind of approach to science. And that is you pick a disease or you pick a cellular model and you follow it through in a very elegant process from a very basic level through discovery after discovery. And that's really where some of our greatest discoveries that have advanced medicine, that have advanced technology have really come from, is that very basic science type of model of following a single condition or syndrome or even cellular interaction. The other kind of research, and I'm sort of generalizing here, but the other kind is something that looks at systems and what I call stakeholder-driven research. And that's the kind of research that I like to do, where we hear from people what the problems are that they're grappling with on a daily basis. And we try to figure out what the source of those problems are and how we can go about trying to find tools, solutions, and approaches that will help them do that. I firmly believe that no one goes to work in the morning wanting to do a bad job. When people go to their jobs, they really want to do it, and particularly people that are in medicine, nursing, social work, they're in it because they really want to help people. That's how they start it. And if they don't feel that way at the end of a day, it's because we have not given them the system and the tools to help them do that well. And I think our research really needs to go about trying to help people get to that point where you feel as good walking in the door as you feel walking out the door at the end of a day. So a lot of what we do is we hear stakeholders tell us what their needs are, what would help them with doing a better job. So the research that I've done through the VA, the RAND Corporation, and UCLA, for example, nursing homes came to me and said, we have a horrible problem with nursing home residents getting transferred to the hospital, and we can't stop it. What can we do? So we helped develop a method to actually go back and take a look at the records of people who were being transferred to the hospital and understand whether or not that transfer could have been avoided, whether they could have been taken care of at a safer, a lower level of care. That's currently now being used in a lot of places so that they can do review of their transfers to different places and to try to better understand systematically what's going on with their transfers. Nursing homes also came to me after the Northridge earthquake and said, you know, we had a horrible experience after this earthquake. We weren't part of the healthcare system. So we went out, we designed a survey, and we went out and we surveyed nursing homes, and we said, you know, what was your experience after the Northridge earthquake? And what we learned was I think, it shed light not just on disasters and earthquakes, it really shed light on nursing home care in general. After the Northridge earthquake, we wanted to survey these nursing homes. So we went to the agency that was in charge of disaster response, and we said, can you give us, you have maps of where all the healthcare facilities were that were affected by the earthquake. Can we have these maps so we can contact these facilities? Because we want to go look at nursing homes. They said, well, we don't have nursing homes flagged as healthcare facilities. So Okay, that's good. So that tells you, that gives you some insight into sort of what is going on, where nursing homes were in this system. When we contacted the nursing homes, we said, so what happened, after the earthquake? What were your experiences? Did any of these emergency response organizations that were out there contact you to offer aid and assistance? The answer was no. We were not contacted. We were not offered assistance. No one asked us what it was, what we needed. But nursing homes took patients from the hospital, and they took patients from damaged hospitals. Well, how did that happen? That was one of the questions we asked on the survey. What they told us was, we just called each other. We didn't have a prearranged plan. We just reached out to the people we knew that we had met, the facility down the street, and we talked to each other and offered to help. And they formed these spontaneous networks among themselves in order to be able to reach out to their colleagues and to help take patients and transfer from hospitals and from other nursing facilities. They felt extremely isolated. They felt that they were supported. We also asked them, what kinds of patients did you take after the event? They were not only taking them from hospitals, and they were not only taking them from other nursing facilities, they actually took patients from the community who were displaced as a result of the disaster. Because these vulnerable older adults that were living with these sort of pieced together social networks, with the earthquake, those social networks were destroyed. And so what those facilities told us was that they were actually taking in people who were displaced from their communities as a result of the Northridge earthquake. So what happened as a result of that? Well, here's the stakeholder-driven question. Frankly, I wasn't really that interested in it to begin with, but I thought, well, okay, if people say this is important to them to find out, let's figure out what's going on. We met with the disaster response folks in LA. Nursing homes are now part of the standard disaster response for the County of Los Angeles. They include them. Our conversation with them started off with, and this is not the people that are there now, these are the people who were there a few years ago, started off with, why, when I've got a disaster on my hands, should I waste precious resources to send staff out to check on a bunch of old people in a nursing home? But again, that gives us an idea of where the nursing homes are in the community. This stakeholder-driven research agenda gave us a very good picture about what we were facing. So I was able to say, okay, here's why. You're going to have a lot more trouble if you don't include them in advance. These are vulnerable populations, and they need your support. They can help you help yourself if you help them plan ahead and be part of the solution. And here's our evidence. Here's what research can do for you. Here's our evidence for what happened after this event. And so nursing homes were included, or now are included, as part of the community-wide disaster planning. They have, many of them are supported in developing their disaster responses. So that's just one example, very small, discrete example of stakeholder-driven research that has led to ways to try to improve what happens in nursing homes in the community. That's one example. Another story, I'm on rounds with the house staff, and they're telling me about this patient. They couldn't examine him. They couldn't talk to him. He was just nasty. He was spitting at them and, terrible. And I'm thinking, oh, my goodness, maybe this guy has delirium. I better go check on him. I knock on the door, and I hear this come in. And I open the door, and there's the aide, and she's standing there, and there's this very tranquil gentleman sitting there with a towel on his neck. She's shaving him. He's not batting an eye. I said, I must have the wrong room. I'm looking for Mr. Jones. And no, this is Mr. Jones. He's here. So here was quality. This was this nursing aide doing quality that we as physicians weren't able to accomplish. She was able to work with this person to have him in a place where he was comfortable and happy. And I think one of our new challenges in research as culture change movements are coming forward is to figure out how we go about measuring that level of quality. We don't have the instruments and the tools to systematically measure that. Why is that important? Some things are just the right thing to do, and we should just do them and not worry about the research evidence. But we have very limited resources, and we're called on to do a huge amount of things. And there's guidelines, and there's processes, and there's things that outcomes that we're held responsible for. And we need help in sorting through all of that to figure out where we get the bang for the buck, where we get the bang for the time and the energy and the resources that we're going to be investing. Because everything's a trade-off. The time that we're spending doing something with a resident is time that we're not spending with another resident doing something else. And we don't have unlimited resources. So what research can help us do, given those realities of our work lives, is to understand where we have an evidence that this is something that's going to help improve quality, improve outcomes, and improve quality of life.